Hello, everyone, and welcome to our Wednesday webinar series. We will wait just a minute or two here as we allow for a little time for folks to be joining us. Okay, good afternoon, everyone. We're going to go ahead and get started. Thank you all for being here, joining us once again for our Wednesday webinar series. Today's webinar is on the VWD guidelines and shared decision making. My name is Kate Namacher, and I'm the Vice President of Education here at the National Hemophilia Foundation. If at any point during this webinar you'd like to ask a question, please use the Q&A feature at the bottom of your screen. We have NHF staff monitoring these questions, and we will be able to propose them to all of our speakers toward the end of the presentation. This webinar is also being recorded, and it will be available to the community beginning on Friday, July 2nd. I am very excited to be joined here today by an amazing team of panelists, Dr. Nathan Connell from Harvard Medical School, Dr. Paula James from Queen's University in Kingston, Ontario, Canada, and Dr. Jean Groh, as well as Nicole Scaffy. We are having some storms here on the East Coast. We are hoping all of our panelists will be able to stay on the entire time, but please forgive us. We are doing our best with technology, a little warning in advance, but we are really excited to have this great team on. And with that, I'm going to hand it over to you.
Great, thank you so much. And thank you to everybody who's joined us today for this. This is one of the last in a series of Wednesday webinars that we have had to talk about von Willebrand disease. And a lot of it centered around the recently published updated guidelines on von Willebrand disease. And so with this session, we wanted to talk a little bit about the guidelines and shared decision making. And the way that we're going to do this session, there's going to be plenty of opportunities to talk about, to answer questions from the audience. But what we're going to do, Dr. Jean Groh and Nicole Scaffy are going to talk a little bit about their experiences as patients and as advocates. And then Dr. James and I are going to talk a little bit about the clinician perspective. How have we counseled our own patients to be advocates for themselves? How do we guide people through these shared decision-making processes? And then we can talk a little bit about what's on the horizon. There is some work being done to help facilitate these conversations with the updated recommendations from the guidelines. And so, but to kick it off, I think it's important to always recognize at the end of the day that we're talking about the experiences of patients and their families and loved ones as they go through life with inherited bleeding disorders and what that means. So I think at this point, I will turn it over to Dr. Groh, and we hear a little bit about her story about VWD. Jean, thank you.
Thanks. Hi. So I'm Jean Groh, and my doctor title comes in a non-medical way. So am I showing up on the screen before I keep chatting here? I feel like I'm not. Am I visible?
I can see you, and I can see the slide with your photo. It looks good.
Perfect. Okay, so my PhD has nothing to do with medicine or biology. I come from the advertising industry, but that has actually allowed me to be a bit more of an advocate for von Willebrands as well. So I grew up in a very large family. There were 7 children, and I was the bleeder. My nickname was Bruiser, which I grew to loathe. And my siblings sort of vacillated between protecting me and being jealous of the attention that I received from my parents. As a child, I had a gazillion bloody noses and I was constantly bruised. I like to think of myself as a Dalmatian. And when I was 5, I nearly died. I had a sledding accident where I hit my head and I had a really, really bad hemorrhage. And it was my mother, I think of, who advocated for me and I believe saved my life. She really leaned on a very trusted and wise family physician to advocate for me in a situation where I wasn't getting what I needed, and I made it. So advocacy is really important. In 1974, when I was 19, I had a tympanoplasty, which repaired my eardrum. And I was told that this was a non-bleeding operation. Needless to say, it was not non-bleeding for me. And in fact, I very clearly remember the physician walking into the room and giving me a name to what had been really a challenging experience over and over and over for me as a young person. And his name was Edward Filmanowitz, and I can remember his face. I can remember everything about him in that moment. So it was very dramatic for me to find out why I was always bleeding. Then a few years before I had children, I met a very wise and kind hematologist in Chicago. His name was Dr. Juan Chediak. And Dr. Chediak, I think, came to my rescue in a time where I really needed someone. I was in a position where I needed to have an abortion, and my gynecologist reached out to my hematologist to get my records, and he refused to release them. So she made some calls through her husband, who was a physician at another institution. Anyway, they connected me up with Dr. Chediak. And from that point on, he really became an incredible advocate for me. He was an amazing human being. Over the years, I volunteered to participate in virtually every single study he did. I donated my son's cord blood. Some of the studies I was in, we were able to, his work was able to get approval for factor product. And I was the lead subject in a 3-generation study. He was very curious why none of my siblings had or appeared to have it. So he did a 3-generation study and found out that indeed I was a spontaneous mutation and it was not the result of inheritance. So he became for me an ally, and he's an ally for all of his patients, as are Dr. Connelly and James Connell, sorry. In my early 40s, after the birth of my 2 children, I had an elective hysterectomy. For me, it was a matter of having the freedom to be who I was, or spending a week out of a month hemorrhaging. So I chose to have an elective hysterectomy. Then I became a mother. And as the mother of 2 children, there's another whole level of anxiety around VWD that comes into play. And by the roll of the dice, both of my children were born with VWD. Could we pop to the next slide, please? And my son, while many boys and men have significant impact from VWD, my son, luckily, was not one of them. However, my daughter was. She had symptoms very similar to me. And in some ways, it was easier because I understood the disease and wasn't as frightened with my children because I had allies. But it was also incredibly challenging because they weren't me, and you don't have control over other people. So my daughter had frequent bruising like I did, and I had an experience which was pretty traumatizing. I took her to a new daycare provider when she was 2, and it was the summer, and she was bitten up by mosquitoes, and she was scratching her arm all the time where she had 3 or 4 bites. And so it was nasty looking. She'd scab up and then she'd scratch them off, and it didn't look very nice. And I had spoken with the provider about the situation, but somehow she interpreted that as my daughter being at risk or experiencing child abuse, and she involved the police. That was an incredibly difficult experience for both myself and my family. And it made me realize just how important to building understanding for the public and professionals outside of medicine, and frankly within medicine, it's just so important. My daughter is now 32 and she just moved to Toledo, Ohio after living in South Carolina for a few years. And in South Carolina, she experienced 3 pregnancies. 2 of them were miscarriages, and she is the mother of a lovely, healthy 2-month-old baby girl who did not inherit von Willebrand's disease. But the reason speaking about her is important today is my daughter's miscarriages were difficult from a clotting disorder. And the first one, she needed a DNC, and the gynecologist suggested she didn't need clotting factor. And my daughter, having participated in studies as well, had a very different understanding of her disease and suggested she did. But when the hematologist on call concurred with the gynecologist, meaning they were going to go ahead with the DNC with no clotting factor, my daughter canceled the procedure and reached out to the hematologist in Milwaukee, who has been our hematologist for almost 2 decades. And he, of course, understood she needed clotting factor, faxed in the information, and 2 days later, she had the DNC safely. But that experience reminds me how important it is for all of us to know more about this disease so that we can be safe. And while I think that her advocacy for herself was incredible, it also struck me that 45 years after I had a tympanoplasty and was finally diagnosed, my daughter was still, at least initially, unable to get the care that she needed. So next slide. So the thing that I just like to wrap up with before I go to my friend Nicole is that I think that advocacy is really important. It's always been important for me, not just for von Willebrand's, but in many areas of the work that I do. And I think that some of the things that I've been able to do, I am really privileged and honored to have had that chance. I was part of the international guidelines team that created the new guidelines that are out. I also sat on the board of the Great Lakes Hemophilia Foundation, and later pulled in an advertising agency that built the Victory for Women's brand. So those things make me really happy. Today, having the opportunity to share my story and hopefully share some things with you also makes me really happy. So I'm going to turn it over to Nicole to hear her story, and then I'll join you in the conversation.
Well, you make me really happy, Jean. So thank you so much for sharing all of that. Fantastic. That was just fantastic. But with that, I'm excited to introduce myself as well. And for those of you who don't know me, my name is Nicole Scaffy, and I am from Pittsburgh, Pennsylvania. And it is currently insanely thunderstorming outside. So if my video is glitchy or I am, it's because there's a giant thunderstorm happening right now. But fingers crossed that we stay on Wi-Fi. But I have von Willebrand's disease along with my 4 siblings, my mom, and my late grandfather. And I work on the education team here at NHF. And I would love for my tech help to show the next slide. Thank you. So I'm going to tell you guys a little bit about my story. And so I have von Willebrand's disease type 1. And one thing I remember when I got that diagnosis was hearing, "You're only a type 1, only a type 1. And it just like kind of sticks in my head. But whenever I was younger, I had significant swelling in various joints. So elbows, knees, ankles, everywhere. But they diagnosed those as hairline fractures. So if you take a look at the picture on the bottom of my kneecap, that's just one example of how my joints used to look. And they're like, wow, the bruising is so significant and the swelling is, it's got to be a hairline fracture somewhere. So let's put a cast on it. So in like all of my family photos, if you take a look on the left in athletic photos, I'm in a cast in a lot of them. And they're all different colors, which is funny because I remember like trying to get every color. But anyways, when that all happened, they called me the wild card in my family. So Jean, I'm the wild card in the bleeder, and I am type 1, but I bleed like very severely. But I was told that for these bleeding, my treatment was a cast. And I was told for the bruising that I had, the significant bruising, to put on a very nice sweater. And a lot of the time when I was in the emergency room, I was asked if I was being abused, and my parents never abused me. So that wasn't happening, which didn't really impact me that much, I think, as much as like Jean's situation. But the summary of this is the incorrect treatment equals joint damage. So unfortunately, because I didn't get the correct treatment, I have some joint damage from that. But, you know, I'm just very grateful that these guidelines are out, and they're very important now because individuals like me now can have access to care regardless of their type. So if I have bleeding, I can have access to treatment now. So I just love that about the guidelines. And then I'm just going to quickly talk a little bit about some procedures that I had in the past, and how they were problematic and how the guidelines can really help maybe solve some of these issues. And I don't think it will solve them today, but I had 2 different procedures done when I knew I had von Willebrand's disease. So I was 15 for one when I had a tonsillectomy. And for that surgery, or I guess, yeah, surgery, I hemorrhaged a couple of days later, and I lost several like pints of blood. But whenever I remember being rushed into the emergency room, and before they do emergency surgery with a tonsillectomy, they like to use, I don't know what it's called, this big match thing. And it's like a giant match, and they try to like cauterize your throat while you're awake. That wasn't very fun, 20 minutes. But after that, I remember it took like 20 minutes or so almost an hour to get me into the operating room. But that whole time I didn't have factor, which I thought was a little bit crazy because my mom's a big advocate in this community, but my parents, I think they were in like panic mode, and it kind of just left their heads. But you know, for situations like that, it's really important that the doctors in the ER know that people with bleeding disorders need their factor like immediately. And then the second example I have is just about when I had my wisdom teeth taken out. So I was treated before all of it, all went well, but I went back in because I felt like something weird in the back of my mouth. And there was a bone shard, I guess, that like came out of my mouth. So the dentist looked, or the orthodontist looked at it, and he like ripped it right out of my mouth when I wasn't aware he was going to do it. He didn't tell me he was going to do that. So no factor before, you guys all know what happens, lots of bleeding. So I just remember that horrific car ride home, like coming home with like blood coming out of my mouth so I could go infused. But again, like he didn't give me forewarning that he was going to pull that tooth, and he didn't think about my VWD and my factor. So I think that there are so many opportunities to educate our different providers around the world about these guidelines. And then the last thing I want to talk about is just with bleeding, I have a lot of bloody noses, I have menorrhagia, and I think we're always advocating for ourselves no matter what. But there goes that big thunder bang. I don't know if you guys heard it, but in 2020, we were all at home, right? But I was on Zoom, and like people would be looking at me on Zoom and they're like, "You look so pale. You look so pale." And I'm in the best shape of my life. So I decided to work out during quarantine, and like I would be out of breath going up my stairs, which I thought was very odd. And like my nails got brittle, my hair was kind of weird, and it was really affecting the quality of my life because I'm a super outgoing person, tons of energy, but I was like quiet and like, which is not normal for me. So the point of this is that you always have to continue to advocate for yourself. I actually called my physician or my hematologist, and I was like, "I'm not feeling good. Can we please check my iron?" And I went in, got my iron checked, and this little chart right here shows you what I was at. So I was pretty much low for the last few years, but look at me, I'm at a solid 65 right now. Look at that jump. So this is the highest my iron's ever been, and I feel like a completely new person. So I think it's just important to always advocate for yourself no matter what stage you are in life, even if it's not a little inconvenient. But with that, next slide, please. And I'm just going to quickly touch on this, but the human impact of inadequate access to care with VWD. So my lovely grandfather, you'll see on the bottom, who has passed, but whenever he was on his honeymoon, he did not know he had VWD, and he had a bloody nose his entire honeymoon, and it ruined the whole trip. So, you know, education, right? And then in addition, he had open heart surgery, and they actually had to leave his chest open because he was bleeding so much until the bleeding stopped. So, you know, there's not much we can do about that now, but, you know, that's just quality of life right there, and why it's so important to know about VWD. And then in my mom's situation, so my mom does speaking engagements as well, and I've actually never heard her tell her story, but I was her tech help like a couple of weeks ago for our event and heard her tell her story. And she really talked about how
Seems as though we may have lost Nicole here for a minute. We will give her a second here to see if we can get her back on to finish sharing about her mom's story. So why don't we go ahead, and we can always come back. Hopefully the storm has not not completely disabled. Nicole's being part of this event here today, but maybe we can move forward and then we'll loop back after to finish hearing her story. So I just went ahead a few slides to our conversation with our providers.
Great, and thank you, and hopefully we'll have Nicole back soon in this very bad storm that's moving across the United States at this moment. You know, to kind of back up and talk a little bit about this, Dr. Paula James is here with me today, and both of us served as co-chairs on these international guidelines. And I think for us, you know, I don't want to speak for Dr. James in this, but, you know, what started with a conversation in a hallway really was serendipity. And I was interested in saying how we could do this. And a Canadian colleague and friend said, oh, if you're interested in doing guidelines, especially around von Willebrand disease, you should talk with Paula James. And so out of the blue, I just remembered sending her a message and we set up a phone call. And what was great was hearing that she had already been thinking about this and working with groups that were wanting to do this. And so it was kind of this really kind of interesting moment for us to come together. And fast forward 5 years later, and there's a publication and all that this has become. And so it really was serendipity at the right time with a lot of people ready to go. So I do want to kind of start off by thanking Paula for being open to that phone call all those years ago, because it really has helped create these guidelines that we have and the wonderful friendships on our panel that have resulted from it. And so for this section, I think Paul and I are just going to chat a little bit about our experiences as clinicians and seeing patients. And so I'm going to play a little bit of moderator and pose some questions. But as many of you have seen on the webinar so far from Jean and Nicole, their experiences, a lot of this is about this diagnostic journey and what does it take from symptoms to getting to even just a diagnosis is the first step. And so, you know, Paul, maybe I'll kick it over to you with this question. What are the common missteps that you see in workup and evaluation when patients finally do make it to you and you're doing the workup for VWD? What do you see the patients have gone through and areas that could potentially be improved?
Yeah, thanks, Nathan. It is funny to think back to that phone call and how far we've come and what good friends we are now. You can speak for me any day, by the way, because you always pretty much know what I'm going to say. So in terms of the things that frustrate me and the missteps that I've seen, the lack of attention to bleeding symptoms, not listening to patients when they say my periods are heavy, sexist attitudes about iron deficiency and about heavy periods, and a lack of comfort and knowledge around what's normal and what's abnormal. Delays in diagnosis. So we know that women can wait 15, 16 more years from the onset of symptoms until they get a diagnosis. And the lack of effective treatments. Because a lot of the things that work for von Willebrand's disease work for other bleeding disorders or in general for bleeding symptoms. There certainly are those things that are special and specific for von Willebrand's disease. But what makes me crazy is when somebody finally gets to my clinic and she's had terrible periods for 15 years and nobody ever did anything and nobody even discussed doing anything. So I think those are the missteps and the things that we really were trying to challenge and address with the guidelines.
Yeah, I definitely agree with you on that. It is always shocking, I think, to have a patient come into clinic and they're referred and here they are. They may have even gone through hysterectomy or menopause and we're just now making the diagnosis, and there were so many opportunities in which to have interventions along the way. And I really want to hone in on what you were saying about sexism in iron deficiency. I think we just heard it from Nicole, how many years she spent with low iron and how well it sounds like she had compensated because of being otherwise healthy. She was able to tolerate it. I think that I had a conversation just recently about what is a quote unquote normal ferritin, and the numbers that we use really don't represent what ferritin should be if we paid attention. And one of my colleagues just recently pointed out to me that another hematologist had said a woman was not iron deficient because her ferritin was in the normal range at 14. And this was during pregnancy. And so, it's one of these things that many of us talk about on Twitter and talk about in conferences, and how do we do that? That's really tough to do. And the next area I was hoping to pick your brain on, whenever you're working on a project, you've always kind of got your favorites, and the favorite things in the guidelines. These guidelines are like our children to some extent coming out of these panels, but I think all of us have a little bit of our favorite. And I'll ask you, Paula, to start, and then maybe we'll ask Jean and Nicole what their favorites are. In the guidelines, and for Paula specifically diagnosis, what was your favorite thing, or what were you really excited to see in the guidelines as a recommendation?
Well, it's such a biased answer because I've spent so much time working on bleeding assessment tools, but the attention that those tools got in the guideline with 3 specific recommendations about how we should be using bleeding assessment tools. And what I love about it is that it costs nothing. We've done a lot of work to make them as widely available as possible. And in terms of a screening tool to see if somebody has abnormal bleeding, they work better than many of the general lab tests that get done for patients. One of the other issues that we often see is that, okay, well, let's say a physician did take the issues seriously, maybe a CBC or a PT-PTT could be done. Those can be entirely normal in somebody with von Willebrand's disease. And so it would be the importance of, because really what a bleeding assessment tool does is encapsulate the bleeding history. So it was the focus on the patient's story as being really where this diagnostic journey needs to start.
That's great. And maybe I'll go to Jean and Nicole in terms of what were you very excited to see in the guidelines for patients to advocate with and discuss with their clinicians? Oh, Jean, I think you're on mute.
I am on mute. Thank you, Dr. Connell. I too love the tools because I think they're helpful to, really get us where you need to be at a foundation level. But my personal favorites are the ones that deal with pregnancy because of my own personal experience and seeing what my daughter went through. I think the guidelines that really help us understand what to do, both in terms of labor and delivery and postpartum. I think it's really, it's life altering. Honestly, I had 2 C-sections because that was the recommended procedure back when I had children for women with von Willebrand's disease. And now with all of the knowledge that we have today, my daughter was able to have a vaginal delivery and it went perfectly well. So it's really exciting to see those kind of changes and the recommendations around them.
Great. Nicole?
So I've thought a lot about this question. I think I even asked it to Dr. Cedeno last time, but I think I'm going to go with recommendation 6 in the diagnostic, but with the panel recommending levels of less than 30, or I don't know, I don't have it in front of me right now, but you know the one I'm talking about, that basically if you are bleeding and you are 50 or below, you're going to have VWD. And for people in the world like me, that levels are somewhat high. That's great news that all would have access to care. And I know I got cut out, but I was going to talk about my little nephew, Tanner, and this is another reason why this means so much to me, but he wakes up probably weekly with really bad bloody noses. And my sister is very aware of this, but he got tested 3 times and it was pretty traumatic. They had to, you know how it is. But every time he's tested, his levels weren't quite low enough. But now with the new guidelines, that's going to change Tanner's life. And it just makes my heart smile. And it's going to change a lot of other kids' lives and individuals. So that is definitely mine. And in addition, the vibe in the room when we talked about this and like all finally agreed on it, like even from our providers, like the excitement and how people are going to actually be able to get their insurance to cover them because they're diagnosed with VWD now, it makes me super pumped. I'm trying to hold it in because I get like too outgoing. I'm going to like knock the computer off the desk, but that would be mine, Nathan.
That's great. And I love that you brought that up because the 30 versus 50 question was also probably my favorite. We talked about that's probably going to be the most controversial. Mm-hmm. And there's a lot of controversy around it and what had been historically there. And I think it's an opportunity for us to make a call for more research. And that was a big portion of that question. Since you talked about 30 versus 50, I guess I can go to one of my other favorites. And that really was around the types of assays that we were using. The standard assay, as many people on this call have talked about, it's the ristocetin cofactor, the ristocetin-based assays. And I just remember being in training and I was working with a laboratory scientist, a hematologist and laboratory pathologist who said, he would give different coagulation tests a grade, like A, B, B minus, like giving them grades. And he would say things like coags, the PT and PTT, I give them about a C+ in their ability to tell you if someone's actually going to bleed. And then he's going through it and he liked the antigen, he liked collagen binding. And I just remember when he got to the ristocetin cofactor, he says, I'm going to give it a D+. And the reason it's not an F is because it sometimes tells you what you think it's telling you. And, there really are some really great assays out there. And it's an opportunity for us to then advocate for wider use of these assays, because I think the diagnostic journey starts with a story, and then you need to get information on testing, and you want to know that that information is accurate. So I was very excited to see how we were able to put that in and advocate for patients to have greater access to this, particularly here in the United States where it is not as widely available. I think the other thing that was kind of interesting and came out of these discussions, as you mentioned, is people get a diagnosis and then they're able to get access to treatment. And there was a lot of discussion during the panels showing the differences and between countries and regions of the world and what difference a diagnosis makes in being able to access those treatments. And I think people really started to open up their eyes that what their experiences were at home was not necessarily what people were experiencing in other countries. So that was a great opportunity. And I think that's woven in. Before I move to the next question for discussion that I have here, I do want to point out Dr. James has done quite a lot of work on bleeding assessment tools, including a self-administered bleeding assessment tool. So if you Google the self-BAT, I talk about it all the time and mention it to people that they can go learn more about it, print it out and take it with them to their doctors. And so it's free and online on letstalkperiod.ca. So a great resource. Also available in English and French, if I remember correctly. So,
yeah,
great. So, kind of next thing, maybe Dr. James can talk a little bit about how do you counsel patients to advocate for themselves when dealing with other medical teams? Things that are, procedures or surgeries that they're going to be having, or even traveling, and when they might unexpectedly end up in an emergency room someplace else because of their bleeding.
Yeah, that's such a good question. So in Canada, we have what's called our Factor First cards. And so they're wallet cards that we actually give to all patients when we clarify their diagnosis and determine whether they're responsive to desmopressin or not. And so everybody gets the card, and it has what their diagnosis is, and then what our treatment recommendations are specific to that patient for major or minor bleeds, and then how you get in touch with us, and then some general advice about the management of bleeding disorders. So we provide that resource to our patients, make sure that we've reviewed it with them so that they understand what we're recommending. We tell patients, if they can, to call us first if they're having a bleed, and to let us navigate getting them into an emergency room, because it goes a lot more smoothly usually if I call or my nurse calls and says, you know, my patient with 2B von Willebrand's disease is coming in with a nosebleed. Here's what needs to happen as soon as he arrives. It frustrates me that it isn't obvious to everyone what should happen, and we're trying our best to educate healthcare providers about that. But we also do tell patients, you know, to ask for what you know you need. And if you're getting dismissed, could you please consult hematology before you discharge me? Please call hematology and discuss specifics with them and see what they would recommend. There's probably lots of other strategies I'm sure that you have, Nathan, and that we'll hear from Jean and Nicole, but those are a few things we do in my clinic.
Sorry, I was muted. You know, we also give emergency cards to our patients to carry. There's a wallet card and a letter that's very clear on how to reach the on-call physician for the hemophilia treatment center at all times. We also try to make sure that if somebody's moving to a new area, that they've, even for a short period of time, that they've got contacts of how to do that. In terms of, you know, calling us, I totally agree. I would much rather hear from my patient that they have a bleed, that they're going to be heading to an emergency room, so that it's very clear. And I can also then expect a phone call from that emergency department along the way. One of my patients went into a hospital in the area a few weeks ago, and she felt comfortable there and didn't want to transfer, and ended up sending me a message through our patient gateway, which I don't get until business hours the next day. And it was just serendipity that when I called her, the hospitalist at that facility who was taking care of her was walking into the room, and she put me on speakerphone, and we had a whole conversation about what the bleed was doing and what she had gotten and where things, how she felt. But I think that, you know, it's really tough to rely on the timing just working out. So, you know, there's always hematologists, you know, on call. They may not be hematologists whose focus are bleeding disorders, and so they may have to reach out and get advice. The next, Jean and Nicole, what have you done if you've been in the hospital, or, you know, and you're coming up against a bleeding event, you're in an emergency room, or a family member's been there? What have you said to the people around you to get connected?
I can jump in, unless, Nicole, do you want to take this one first?
You can go first, Jean. You seem ready.
Okay. All right. So I concur with everything you've said, and I really like the wallet cards and the letters. I found them to be very helpful. When my children were little, before we had those things, I carried detailed instructions in my purse, in the glove box, in my car. I had them everywhere. But I think it's really helpful to give that kind of information in detail and have a sit-down discussion at the school where your children go, at their daycare center. If they have a handful of close friends, have that conversation with those parents and give them that information. I think, you know, you just never know. Maybe you're not available when an emergency happens. And I think the more people who understand you or your child's circumstances, the better it is. And then I think just being a mama bear, frankly, or a daddy bear in the ER, if you're not getting what you want. Dr. James suggested just saying, why don't you check in with hematology? I think, you know, that's certainly sending a strong message that you believe you need a deeper consultation about the situation at hand. So that's what I can add one more thing. Also in travel, I've traveled a lot for my work, and every time I go to a foreign country, I call either my local HTC, sometimes NHF, and then I heard the CDC can help too. And there's a network of hemophilia treatment centers around the world. And I always I have a printout of all the places within hopefully 100 miles of where I'll be, that the major HTCs are and who I need to contact at those. And I always give that list if I'm speaking at a university, the people I'm going who are leading my speaking engagement, they get that in advance, so that I'm not shy about talking about the fact that I have this disease, so that other people can advocate for me if I can't advocate for myself.
I would agree with that, Jean, as well. I'm kind of 100% with you in that boat, that the people around me definitely know that I have a bleeding disorder. Even in college, like when I was, having fun, like the friends were at the party, somebody at that party knew that I had a bleeding disorder no matter what. And I also try to use those moments whenever I am in the ER as teachable moments, or in the hospital. I remember being in the hospital for quite a while for actually some different stomach issues, but I remember before they had to do some type of scope that I had to infuse before. And they were like, they just like kind of looked at the boxes back here and like scratching their heads. They're like, what? And I was like, come here, everybody come around. Okay, this is this. And like, I like walk them through how to do it. And I'm like, and this is why your dose is this. And they're like, wow, that was so helpful. Like, I only got maybe a paragraph about this in medical school. So I also understand it, like, vulnerable brands isn't like the biggest thing. We don't see it on all the billboards in the world. So I also understand why some folks don't know, but also just like speaking up as well. Like I've refused to have procedures because I haven't had humate, so like, or factor, but you really have to just advocate for yourself. And I learned a lot from my mom to do that, because she's got pretty aggressive at some points, but I've also learned aggressive doesn't always work. Like you have to tread carefully on the type of aggressive that you use. Yes, speak up for yourself, but if you like yell and get angry back, like their vibe, I think will just be the same, and you're never going to meet in the middle. And how Jean touched on, like when you travel, I kind of did something similar. I reached out to my HTC before I studied abroad in Italy, and he sent me like this awesome sheet of HTCs because I was going to multiple towns. That was the problem with the trip. So like we had to find in all these remote towns. So they were very, very helpful. So, I encourage you to reach out to your HTC for that. Always have that travel letter. Our travel letter got a big upgrade. There's like so much on it now. Like there's a QR code they can scan and get into things. Like, so really utilize those resources. And the other thing, and I'm not really sure if it has to do with this topic, but they gave me this little yellow sticker to put on the back of my car in PA. And so like if I'm in an accident, they'll see that yellow sticker and look in my glove box, and they'll read my whole little paper with what needs to happen. So those are a couple of my thoughts.
That's great. And I think, one of the concerns that people have is walking that fine line between, being an advocate for themselves and potentially being, an annoying or overbearing patient or an overbearing family member. And I think that, one of the things that we understand as clinicians for the bleeding disorders community is how many times people have been dismissed or have been overlooked. And so, I think open communication as much as possible and engaging resources, your own, clinical team, the social workers and the nurses that know you well at your HTC, especially if you're going to another location, will be important. The other part to this is, a lot of this isn't necessarily VWD specific. A lot of this we're talking about applies to many other bleeding disorders. And so one of the things is that I think that's been great is that people with bleeding disorders have started to become advocates for each other and other bleeding disorders in the community, recognizing the shared overlap. And so we're kind of moving from this personal advocacy to how do you advocate on a societal level? And so one of the things that I wanted to at least kind of bring up is how people can be advocates for others with bleeding disorders such as VWD. And one of the interesting things is speaking with policymakers. The NHF as well as the local chapters all have opportunities for people to meet with their legislators and meet with local policymakers. And how do you connect with these local groups? Well, it's sometimes very hard, especially if there's a new diagnosis. It can be very overwhelming for people. And I think that we oftentimes rely on clinicians, and we're there as the clinical team to be able to support people. But it's also nice to have a group of people who have gone through this similarly and maybe can provide a different perspective. And so making sure that if you have this diagnosis, that you have been connecting with other people with bleeding disorders, because you'll realize how much overlap there is in common. As part of this, pushing for research is really an important aspect of our work. And so one of the things I think that I would love to hear from Dr. James, who is a researcher in the lab and also on the clinical side and covers a spectrum of VWD research, is to hear a little bit about your thoughts about research and what are some of the ways in which patients can get involved, what types of research studies are out there, and how can patients and family members participate? And how do you talk about research studies to patients when you're seeing them, so to guide them through that process?
Yeah, that's a great question. Research is completely integrated actually into everything I do. And so not during COVID, because I wasn't able to see many patients in person, but we're getting back to it now as Ontario's coming out of our third wave. And so my research team is in clinic with me all the time. And so And my patients have gotten to know that we care very much about advancing the science around von Willebrand's disease. So lots of times they're saying to me, what's the latest? What are you working on? What can I get involved in? And so we make sure that our patients are aware of what we're doing and invite them to participate if they're interested in whatever it is that we have going on. But I think in terms of looking at what's happening, in Canada, there's the Canadian Hemophilia Society that funds research focused on bleeding disorders, and on their website, it's clear what studies are going on. I think the same is probably true in the US with the National Hemophilia Foundation. And so connecting with that organization to find out what might be going on in your area. The World Federation of Hemophilia as well might be another resource. The Foundation for Girls, for Women and Girls with Blood Disorders. So I think there are a lot of organizations that really have furthering the research mandate and generating new knowledge as part of their goals and their objectives.
I definitely agree with you that, it's an opportunity, especially in larger centers, that there's always clinical studies going on and opportunities. And I think it's important that people recognize all of these are voluntary, and that we see it as a way to advance knowledge and improve care of people living with bleeding disorders and VWD. But you don't necessarily have to be in an interventional trial. You don't have to be in a trial in which there's medication. Just like in your lab, you're looking for people to provide blood specimens for testing. And it's also the way that we train and teach the next generation of scientists, is by having them design a project and work through it, and how they think about the basic science and how that gets translated into clinical care and change in health outcomes. One of the other things is thinking about how patients can advocate for it. And for Jean and Nicole, maybe I'll ask the two of you to comment. When you were hearing the panels talk about priorities for research, what were you thinking? What was going through your head, and how did you kind of react to that? And was there anything that you were kind of surprised that we did or didn't put into those guidelines about research?
That's a great question, Nathan. I think that there was a lot of research that the group talked about. And to be quite honest, I don't know if I can think of one off the top of my head. I'm more of I need a second to think about it, then come up with an answer person. But I just remember if something didn't get graded as high as we want it, we're research, make sure there's research there then. So if something didn't get prioritized, I just know we were well, then we got to do a research study there. So maybe not the most helpful answer, but what do you think, Jean?
Well, I have to admit that I was surprised by the lack of high quality evidence in general. And I think, it has certainly nothing to do with the passion of the physicians and the other experts on the team. It's, you know, funding just goes in different places. And I just think that von Willebrand's hasn't been as robustly studied as a lot of other diseases. So I would like to see more studies, but you never know. The other thing that I kind of thought was missing in our discussion that I think is at least important to talk about, and that's I don't know how to say this. When we think of communities of color or rural communities, oftentimes they don't have access in the same way that urban patients do. And I mean, I think perhaps this is one of the silver linings of COVID, and there aren't a whole lot of silver linings to COVID, but I'd like to think that maybe we're having more discussions with people who haven't had access, and we're pulling them in a way now because we just have more connections. And I know that's not specific to our disease or research, but I just think I'd like more thought about how we reach underrepresented communities, whether they're people of color or people in rural communities.
That's a great point, and I think I'll use this as an opportunity to point out that NHF is doing a state of the science meeting later this year, and there are multiple working groups that have been focusing on bleeding disorders. There's one focused on VWD. I am part of the group on diversity, equity, and inclusion and health services research, and so that was given its own working group to really dive into these areas of access and how bias exists, and how do we even just start to tackle it by measuring it. And so you'll see a link here for the State of the Science Research Summit and the information, and I believe registration is open. If not already, it will be soon. The last thing, so before I kind of talk a little bit about decision aids, patient decision aids, I do want to say questions. We'll have time for a few questions before we finish up here. And then, so please put your questions into the question and answer section, and we'll pose them to the panelists. And the last thing I wanted to talk about is patient decision aids. And so with the guidelines, you'll see information about strong versus conditional recommendations. And conditional recommendations really do require a lot of thought because of the fact that many patients will choose different choices in their decision making related to it. And that's because we really have data that suggests that you could go either way as a reasonable option. And to help guide people through this, there are oftentimes decision aids in many different areas. Think about the decision aids that are available in oncology and cancer studies as well. And so we're going to be helping develop those. So hopefully in the coming years, you're going to start to see some decision aids to help patients and their families have a discussion with their clinical team to make these decisions in a shared manner. So the only question that I have right now, I think we touched on this a little bit. The only question that's in the question and answer is, what's the best way to support a friend with a bleeding disorder? And I think, Nicole, you talked about this a little bit, and about, you know, if you're going to go to a party, have a friend. Like, what do you tell your friends? What's their responsibility as it relates to you?
Their responsibility is, if I'm unconscious and hit my head, I need to go to the emergency room and have my medication, and they need to call the number on the back of my medic alert bracelet, or they can call ICE in my phone. I have both. So that's kind of what I normally tell my friends when I go out, but mostly a lot of them know, like, I've been educating them for years. If you know me, you know that I will educate you on VWD. So they're all like, oh yes, we know this much, you need to get to the hospital, your factor first. So like, I think I've trained my family and friends very well to be prepared, but I've also learned some from amazing advocates as well. Yeah.
And
what
Jean,
was your question again? Tell me that one more time, because I had another thought. What was the original question you asked?
well, how can people support their friends or family members with bleeding disorders?
So I talk about that way, but another way actually is I was in NHF's NYLI group, the National Youth Leadership Institute, and I still talk to this day with a lot of the girls and gentlemen in that group. And I actually recently was talking to the one girl who was having some really serious bleeding issues. And like, I love that I can connect her with other people. I also love that I can check in with her while she's in the hospital and be like, how's your day going? Send her funny gifts and memes. But I think just like being there to support your friends when they're in their low times, because I know I've had my low ones and it felt amazing to actually have some support when I needed it. So I always try to offer that whenever I see someone struggling as well. And you're like, did you do this, this, and this? Okay, do I need to call some people for you? And I kind of just, that's how I support my friends too as well. But yeah, what about Jean? What do you think, Jean?
Nicole, you are an awesome friend.
Oh, thank you.
Yeah, seriously. If I lived in Philadelphia, I might recruit you. So the one thought that I had to add on to what Nicole said was just honestly, speak truth to your friend, like just ask them what they need from you. How can I help you? I'm your friend. What do you need from me? Because I think sometimes it's just a human thing. We don't want to ask for help, or we feel like we don't want to be a burden and all those other blah, blah, blah things around our psychological makeup. But I think if you just open up yourself to them and say, I'm here for you and just tell me what you need, it's really an affirming statement to hear that from someone. So.
Okay, so sounds like there may be some more questions, Kate.
Yeah, thank you all so much. This was hugely insightful and helpful. Let me stop my share so we can make sure to really see everyone here. We did have a few other questions come in, and I know we are limited on time, but we'll try and squeeze a few in, especially around this concept of diagnosis and undiagnosis. So, right, we know that people might get a diagnosis and then maybe, that hematologist leaves or retires, or maybe that family moves to a new state or new area, and maybe just throughout their lifespan, right, aging, and then are told when they see a different or new provider that no, they don't have a diagnosis of VWD anymore. And or the sort of many that are somewhere in between, right? So what might the guidelines actually mean for folks that have experienced this, and how can they utilize this as a tool?
Paula?
Do you want to do it or do you want me to?
If you could do it.
Okay. Yeah, this is hugely important. And we specifically have a question in the diagnosis guideline that addresses this because it comes up all the time. And so our recommendation is that the diagnosis does not get removed. And the wording that we used is that it be reconsidered. And it's very clear if you read what we're talking about under that recommendation that we don't want patients to be abandoned, that we recognize that it's normal. It's a normal process of aging for clotting factor levels to go up. And if they've crossed into the normal range, that doesn't necessarily mean that that patient isn't at risk for bleeding. And so we very clearly say, do not take the diagnosis away. Don't discharge that patient. There still are things that can be done to treat or prevent bleeding. And so that's a great question that aligned very clearly with what we were thinking about when we were trying to pick the priorities for that guideline.
Thank you. I would also like to just hear from our panelists about like, what is, the topic today was shared decision making, right? And so we heard a ton about amazing advocacy, right? Both for yourself, for your patients, for maybe your peers or friends. So that's all really wonderful. But explain a little bit the nuance of shared decision making and your own perspectives on it. From a provider perspective, what does that really mean for you? How do you implement that? And same on the consumer patient side.
Yeah, there are so many things in hematology due to lack of clear evidence to suggest that everybody should go one direction. So we do this quite a bit. And I always start off the conversation by telling people, this is a normal thing, X, Y, and Z that we're talking about. And I will say, there is no absolute right or wrong answer to this. And it may sound like you're coming here and you expect your physician to say, this is what you should do, but there is no right or wrong answer because everybody may choose differently, but it's important for you to have the information so you make the choice that's right for you. That's the right decision. And so when you start off the conversation like that and you provide information, I think we have to trust in patients that they want information, but they oftentimes will give signals to their clinical team about what they're willing to abdicate in terms of responsibility or decision making. And everybody has the right to make their own decisions in that regard. So I provide information. I stop every so often and say, I know I've been talking a lot about this. What are you thinking? Or what can I try to explain differently to try to make sure? And I always say, we don't have to make this decision right now. We can come back to this in a couple of days, a couple of weeks, so that people can take that time. And Jean and Nicole, what have you kind of, from a patient side, what does shared decision making mean to you in that regard?
I think of a very specific example for myself, but it means making a decision that is going to be comfortable for me and my physician. And I think that one thing that I always struggle with is birth control wasn't something I ever wanted to take. It was not something that I felt like was going to be good. There were a lot of issues with my family and mental health with it. So I advocated very strongly. I did not want birth control. And that was the only option for type 1s back in my day, like however long ago that was. But I think that I was really able to, fortunately, advocate for myself to have access to that. But just talking with my doctor about it, like she really did push strongly for it, but then we both were able to make a decision that worked best for me and her. So I'm not bleeding anymore. I'm getting the factor. I don't have to take the pill I want. So we're actually right. Her patient's not bleeding. I'm happy. So everything is good. But we made that decision together versus like, you just have to take this and you don't have a choice. So to me, it's like kind of working through those things. How about you, Jean?
Honestly, both of you, I think, spoke to what I would say. I mean, you just have to have a very open, honest, candid conversation. And it does come down to, it's your body, it's your life. The decision needs to be the patient's, it needs to be ours. And if you have a good relationship with your doctor, you're probably going to land very close to the same page. And so I think it's just building that connection so you really trust your physician and your physician respects your decision. So.
Well, thank you all so much. I know we are already a couple of minutes over time and there's some more questions coming up, but please, I just thank you all. And, this group has always been available. If people have questions, please feel free to reach out to, and I'm happy to field those to our panelists here since we're wrapping up our time. My email is knammacher@hemophilia.org. I can throw that in the chat, but knammacher@hemophilia.org, because this conversation around VWD and continuing to push us all forward and having better access, treatment, and care is absolutely, we are still just beginning this journey together. So truly, thank you all. I will also just put one additional thing in the chat. There was a good conversation around research. We have one other way for community members to participate in research through NHF. If you're interested in learning more, our community voices in research, and we have, really do want to make sure that VWDs represented, women are represented, all of the groups that we've been discussing today, so we can understand this over time and the impact. And then finally, this webinar has been recorded and will be available on Friday, July 2nd at hemophilia.org. You can go under our events tab to see all of our archived webinars. Also available in the events tab is our upcoming schedule for our weekly Wednesday webinar series. So thank you all so much for joining this afternoon and have a wonderful week.
Thank you, everyone.